It's really lovely to be here today. Thank you for giving me the opportunity to talk to you about the James Lind Alliance and how we set priorities working with patients, carers, and clinicians. I wanted to start by saying that thousands of patients have been involved in JLA priority setting partnerships over the years. So they've contributed their knowledge, skills, and experience in so many different ways, being part of steering group meetings, taking part in workshops, and bringing their insights to help shape research agendas in all sorts of health conditions and settings. So can I have the next slide, please, Oliver? Thank you. So what is the James Lind Alliance? Well, it's an initiative that was established in 2004. It's a method that brings patients, carers, and health and social care professionals together in what we call priority setting partnerships to agree the top 10 priorities for research in a particular condition, health condition, or a setting. And I've got some pictures there. That's a face-to-face priority setting workshop there. And there's an example of what happens online. May I have the next slide, please? So who normally decides what gets researched? Well, typically, research is decided by researchers themselves and or the pharmaceutical industry and maybe funders. They're the ones who decide on the research that's undertaken. But we know that there's considerable evidence that there is a mismatch between what patients and health professionals want to actually see researched and the research that gets done. This can mean that research can fail to address the questions that really matter to the patients and health professionals who need to make the decisions in their everyday lives. And if I can have the next slide, I just want to give you an illustration of that mismatch. So this is just a graph. We don't need to look at it in too much detail, but this is a graph just to illustrate that mismatch. This is from a study from 2015 that Sally Crowe undertook. And she compared the interventions that were mentioned in commercial trials and non-commercial trials compared with the priorities from JLA PSPs. And the results show very clearly that that mismatch, the priorities of patients are in that first column, and they tend to focus on things like education, training, psychological, exercise, complementary interventions, whereas the trials and research that's being done by registered commercial trials have a much stronger focus on drugs, vaccines, and biologicals. So that's just to illustrate the sort of differences in the different priorities. May I have the next slide, please? So in 2004, Sir Ian Chalmers and his colleagues, there's Sir Ian Chalmers on the left there, who's also a co-founder of Cochrane, he developed a methodology to identify and agree priorities that focus on patients and clinicians. He wanted to give a voice to the people who don't normally get to influence the debate about what should be researched. And the point of this is to make sure that the right and most important questions are being addressed by research and ensuring that we reduce the waste that happens in research because the right questions will be asked. Now have the next slide, please. So why is it called James Lind? I don't know if any of you have heard of James Lind. Well, it's called James Lind because he is considered to be the inventor of clinical trials. He was a naval surgeon 250 years ago on HMS Salisbury, and he found that a lot of his sailors were suffering the effects of scurvy. And there were lots of remedies and treatments at the time. And so he decided to test all the different remedies, and he divided 12 sailors into a randomized trial by giving them those different remedies. And he found that it was actually the citrus fruits, that giving citrus fruits as a remedy were the ones that they helped them most. So he is the inventor of the clinical trial. May I have the next slide, please? Oh, there's some lemons. I Didn't know that slide was interactive. There are the different remedies. So what are priority setting partnerships? Well, this is in a nutshell what they do. They are focused on patients, carers, and clinicians working together as equals. They focus on a single condition or a health and social care area. They identify evidence uncertainties, those unanswered questions for research. They then prioritize the most important, and the output is a top 10 list of priorities. And then the point of the PSP is to then promote that top 10 to researchers and funders. May I have the next slide, please? So the JLA method that I'm going to tell you a little bit more about in detail in a minute, slightly sometimes varies depending on the context and the area, and Zalalem's going to tell you about his context and how he has done his priority setting working with the JLA. But all PSPs adhere to this set of principles. The first is around transparency of process. We want to make sure that it's very clear what decisions have been made, and how the decisions have been made, how they are, and that they're shared, and it's open and transparent. That there's a balanced inclusion of patient and carer, clinicians, and interests and perspectives, so there is an equal voice. And all PSPs are overseen by a JLA advisor who chairs them and ensures that there is that balance of perspectives. We exclude professionals who don't treat patients because we know that researchers and others have their own ways of deciding research. So this is about giving a voice to the people who don't normally get to influence the research agenda. And we exclude also those that may have competing interests, such as pharmaceutical companies. And the final principle is around ensuring that the existing evidence base is used to make sure that questions that are the questions that go into the priority setting are actually unanswered. So all questions that have been identified are first checked against the existing evidence. May I have the next slide, please? I'm going to talk you very briefly through the priority setting process. So a typical PSP, and again, Zalalem's going to give you an illustration of where his circumstance has been a little less typical, but a typical PSP, one say that's based in the UK, takes about 12 to 18 months. And it starts off working with one of our JLA advisors who are expert in the JLA method and principles, and they support the PSP through the life of the project. So a steering group is formed, and that steering group is made up of equal numbers of patients, carers, and healthcare professionals where possible. The next step is to obviously agree the scope of the PSP, and that's set out in a protocol that's published. And then the next step is to gather unanswered questions, gather those evidence uncertainties, and typically in the UK, that data gathering, that evidence uncertainty gathering, is undertaken through a consultation survey, usually an online survey. But we always ask PSPs to consider how best they can reach their stakeholders. So that may be through doing focus groups, face-to-face interviews, or all the different ways you may need to reach that wide range of stakeholders of that condition that the PSP relates to. Once all those unanswered questions are gathered in, and we allow those questionnaires to be very open-ended so people can describe their concerns and questions. We don't expect participants of those surveys to be able to articulate a research question as such, but they can share their experiences in that survey. And it's for the PSP then to extract, well, what is the evidence uncertainty? What is the research question in what is being shared with us? So all that data is then analysed, and summary research questions are created from all that data. So that's a job of the priority setting partnership and the information specialist who works with them to sort all the data that's gathered and to create from all that data summary questions. The steering group oversees all of that work, and that steering group again ensures that the voices of the patients and of the clinicians are being appropriately articulated in those summary questions for research. Once those summary questions are agreed, they're checked against existing evidence because, as I said, we don't want to put anything into the priority setting part or to be prioritized that's already been answered by research. We only want to prioritize the unanswered questions. Once the evidence checking has been done and we've taken out all the answered questions, the unanswered list of questions, a long list of questions, then goes into a shortlisting, or we call it an interim survey, a shortlisting survey, so we can get that long list of unanswered questions down to a shorter list that can then be discussed at a final priority setting workshop that is a day of discussion and deliberation, which can be online or ideally face-to-face, that is made up of patients, carers and clinicians coming together to share experience and knowledge. And the output of that day of workshop is a top 10 list of priorities. May I have the next slide, please? And I just wanted to show you some pictures of a final priority setting workshop. We love to do them online because it's great for people to get together and have that knowledge exchange. But since COVID and subsequently, we have developed the priority setting workshop method to be able to do it online. And of course, it can have its advantages because it means that we can have people participate that perhaps wouldn't necessarily be able to participate if the final workshop had to be face-to-face. So I think there might be another click there. There's some pictures of how we work together in a final workshop. We use, when they're face-to-face, we have cards that are laid out on tables so people can see what those priority questions are, and we can physically move them around in the discussion. And if you click again, please, Oliver, you can see we do that. We have an online version of it as well. May I have the next slide, please? So this is to say that there have been now over 150 completed JLA PSPs in all sorts of health conditions, and I can't list them all on one slide, so there's just some examples here. So epilepsy completed in 2022, children's cancer, type 1 diabetes. PSPs also take place in health settings, so there's been a PSP in emergency medicine, intensive care, and in primary care. And although most PSPs have taken place in the UK, we now have a number of international PSPs. Canada has undertaken many PSPs, as well as now more PSPs are taking place in the lower middle income setting. And I hadn't mentioned before, but PSPs are self-funding. The JLA doesn't have a budget to fund PSPs. So groups who want to undertake a priority setting partnership have to find their funding to do it, and they come to us and we support them through that process. And there's just some example of the sorts of funders in the UK who have funded priority setting partnerships in the past. May I have the next slide, please? So here's just to say that, you know, increasingly the reach of the JLA is broader and wider. We've had, as I said, over 22 PSPs have taken place in Canada. There's now a number in Australia, and there's some now that have a truly international feel that the PSPs are crossing boundaries as well. Can I have the next slide, please? So, as I said, the output of a priority setting partnership is a top 10 list of priorities, and it is up to the PSP to promote that top 10 to the funding and research community to encourage the uptake. This is about influencing what research gets done. So there's just some examples of how different PSPs promote and disseminate their top 10. May I have the next slide, please? So as I said, the method, the 12 to 18-month method is really just the start of a process of then trying to influence the research agenda. So we encourage PSPs to disseminate their findings, and there's a range of things that they do. They may have launch events. There are many journal articles written about the priority setting exercise that they've done. They attend conferences, and we encourage lots of social media. All the priority setting partnership outputs are also on the JLA website. So the top 10 priorities are disseminated, but there's a translation piece that has to happen. So the top 10 priorities are generally not worded like a research question necessarily that a researcher or a funder could just pick up and put into a research application. So sometimes the broad priority area that's been identified has to then be translated into a specific research study. And here's an example. This is the first ever priority setting partnership that took place in asthma. And question number 7 of the top 10 was, what are the benefits of breathing exercises as a form of physical therapy for asthma? And that did translate into a research study that was undertaken by a team in Southampton that was funded by the National Institute for Health and Care Research, Health Technologies Assessment Programme. And finally, they published, it was 10 years after the PSP, the findings of that study were finally published in the Lancet. So it's just an illustration of how long sometimes it takes from identifying a priority to getting the answer to that priority. May I have the next slide, please? So obviously the aim of a PSP is to influence the research agenda, but I just wanted to touch on the fact that those people and patients and clinicians who are involved in priority setting partnerships, it can have an impact on them and the people they work with in the professional setting as well. And it's just, I wanted to just share 2 examples of quotes from people who have been involved in a PSP. And this is from a parent who was involved in the Epilepsy UK PSP, and I was lucky enough to be part of that final workshop. And she said, I then learned of the opportunity to participate in the UK Epilepsy PSP workshop and felt that I could add huge value by not only representing other parents like myself, but giving my little girl a voice. And I think that feels quite powerful. And may I have the next slide, please? And this is from a clinician who took part in the rare inherited anemias PSP. And she says, this has changed how I practice medicine. It has changed my understanding of what it means to listen to patients. It has changed the language I use when I speak with them. Most importantly, it's changed my vision of how to deliver the care we give them. It has made it our vision. So that's just an example of the impacts of when people do get involved in JLA PSPs. May I have the next slide, please? So this is my final slide. It's just to say, if you want any more information about the JLA, please do contact us. We're a small coordinating team. There's an email address there. You can see the JLA website, the email address there, and we are on Twitter or X at Lind Alliance. And I'll be really happy to take any questions at the end. Thank you for your time.